Good evening. My name is Dr. Gillian Kernahan, and I have the privilege of being the President and CEO of St. Joseph's Healthcare here in London. And I'd like to thank you for joining us tonight. This is a wonderfully informative community health discussion, part of our DocTalks lecture that's sponsored by CIBC. We host this presentation in partnership with the Foundation, and it's through the work of our Foundation and the support of a giving community that St. Joseph's is able to continually improve specialized care for you and your families. Some of the most accomplished physicians in the world are working within our many programs at St. Joseph's. Tonight's presenter, Dr. Tim Doherty, is one of those impressive physicians. He told me I shouldn't say too much about him, but he doesn't get the podium at the moment. He will be sharing with us how his team is tackling the problems of activity and mobility. As most of us are aware, these challenges affect many, ourselves as well as our family and friends. We're very fortunate to have this accomplished physician, researcher, and teacher and leader in our system presenting to us this evening. Please join me in welcoming Dr. Tim Doherty.
Thank you. I'm going to do this again at 6 in the morning on Saturday for the other 100 people, so if you want to tune in, I want to make sure everybody gets a chance. Now, it's great that so many of you are here, and Jillian, thanks for the kind words. And I've got the podium now, so be careful. This is a topic that I've been interested in for a long time, and maybe I'm not very creative because I've been doing research in this area now for about 25 years. And what I hope to do this evening is tell you a little bit of a story about my research and our team's research, talk a bit about the science, and some of the very specific things that we've done to understand how nerves and muscles change as we age. And then I hope to have quite a bit of time at the end to talk to you about some practical things around what we can do as individuals as we age to improve our nerve and muscle health. I might blow by some things pretty quickly. If I do, it's not because they're not important, it's because I'm running out of time and I talk too much. So I will try to stay on time, but we'll do our best. So Jillian just mentioned most of this, but one of the things that's interesting is that aging has become not just sort of a Western first world phenomenon. We're aging globally. So if you look, 5% of the world's population is going to be over 80 by 2050, and that's remarkable. And that's for all kinds of reasons: improved public health, improved nutrition, improved fetal and maternal health. And so this is not just a Canadian, not just an Ontario phenomenon, it's a worldwide phenomenon. And so when we think about the challenges of an aging society, and lots of folks in this room might relate to some of these challenges, but not everybody, is that we're living reasonably long lives. As we get older, often disability does increase. And that leads to problems with mobility and issues like falls. And falls leads to fear of being out in the community, even doing things in our own home, that then leads to further disability. And so if we can impact that, even a small amount, we can have a huge impact on people's health and their quality of life. So I have thought about this and cared about it for a long time. And as a physician and a scientist, I have always been interested how nerves and muscles relate to activity. And most of these are pretty positive stories, doing calisthenics, out for a walk in a park, golfing, curling. I am fortunate to work with also many patient populations who have significant impairment and disability, have problems. And one of the things that I get excited about is seeing them improve and seeing them get to the point that they can then re-enter parts of their life and do that. And that's what's inspired me to be a rehab physician over the many years I've done this. So why else do I care about this? Well, I had a bit of a funny pathway to becoming a physician and a clinical researcher. My son would say I started off as a gym teacher, and I was a gym teacher, physical educator. He says, gym teacher, Dad, Con Ed. You're never a king in your own kingdom, everybody knows that. And so I did a phys ed education degree at UNB and couldn't find a teaching job within the 20-kilometer radius of Fredericton where I grew up. And so the world came to an end and I said, I don't know what I'm going to do. And so I went to Dalhousie and did a master's degree in exercise physiology or kinesiology. So I went all the way to Halifax, like the end of the world for me. And got kind of excited about research and found out that there was a Center for Activity and Aging. at Western in London. And where's my picture? Here we go. Here's the Mount, and many of you will know this building on the corner of Windermere and Richmond. And the center used to be in that building, is now relocating. And I was fortunate to spend 4 years doing research there with Bill Brown, who's a neurologist, and Bert Taylor, who was a kinesiologist or physical educator at the time, and I studied aging and muscle function. And then I started to work with clinical populations. I thought, gee, it'd be pretty cool to go to medical school and be able to do this, with patients. So I went to medical school at McMaster and then came back initially to UH, and now I've been at Parkwood for about the last, 15 to 20 years. Now I'm going to tell you another story, because I like to tell stories, because stories are what drive things home, and I'll try to keep it together for this story. So the woman up in the top left is my maternal grandmother, Muriel Harlow, and she died in 1993, the summer that I finished my PhD and went to medical school. And she is from the northeast corner of New Brunswick in an area called the Miramichi. Any fly fishermen in here? If you're a fly fisherman, you probably know the Miramichi, because it is one of the better fly fishing rivers in the world, although it's been fished out a little bit like a lot of places. So she was from the Miramichi, and she then moved to St. John and lived in St. John down here in the southern part of the province. And eventually they sold their home in St. John and moved out here to Hammond River. And how I found and stole this from some place called Alamy, I never know. But this is the house that they lived on. I just found this with a quick Google search. And so she loved to fish. And there's a pretty steep bank here, and she had to get down that bank to get to the salmon pool to fish. And at about 80 years of age, so I was just kind of starting my PhD work at the center, she said to me, Timothy, because she called me Timothy, don't call me Timothy. She said, Timothy, I never thought my body would let me down. And that stuck with me. I said, yeah, I don't hope mine doesn't let me down someday. But our bodies do change as we age, and we hope they don't let us down. And in some cases they do, and there's things we can do about it, and sometimes there's things we can't do about it. But that has always stuck with me, and it's part of the reason I think why I've had passion for this. So I'll just move on quickly. So let's put a little science to this, and Doherty will stop telling stories because he'll lose it. So if we think about this globally, and this is just sort of a model of thinking about what happens to our nerves and muscles, or what we sometimes call the motor system as we age, most of us are going to be roughly our strongest around 25 years of age. And forget people who are elite athletes or who are training at a very high level. This is day-to-day activity, maybe doing recreational activity, and most of us will peak with our muscle strength and function somewhere in this ballpark. And then it does change, and most of us will reduce muscle mass and strength into our middle age. And somewhere around 75 years of age, there's a whole lot of research that shows there's a more precipitous decline, a more rapid decline in muscle mass, strength, and then function. And that leads to this whole concept that we refer to as frailty, where we have an increased risk of falls, independence sometimes is reduced, and this is an issue that affects many, many people, because as we said earlier, many people are living well past 70, 75 years of age. So what can we do to change that, and what is it that actually happens to produce that? We're going to talk a bit about that. So this is a pretty busy slide, but it's simple in many ways, because all it shows is that if we take 100% of strength of the knee kicking out muscles, so the quadriceps, and just test them isometrically. So you're going to push as hard as you can by extending your knee. And here's 100% of a typical young person, 20, 25 years of age, often a kinesiology or phys ed student in a lot of these studies. And then if we take healthy men and women between 60 and 80 years of age and do the same thing, you see there's some variability, but somewhere in the ballpark of around 30% of strength on average is lost between about 60 and 80 years of age. 80 is going to be a bit more, 60 a bit less. This seems to be true for most muscle groups and for men and women. So at the best, and these are really the best, these are people who have been selected without disease, usually active, independent living, not using gait aids and so on, they're still going to lose about 30% of their strength. So let's think about maybe why that happens. The other issue is that power reduces as we age. So not many of us do many things where we're static. Okay, here's my knee extensors working statically, isometrically. That doesn't happen very often. We move, and we're made to move. So most of the things that we do functionally don't require just strength, they require power. And so any of you that remember grade 11 physics, I don't. So I'm not an orthopedic surgeon. Power is strength times speed or times velocity. And if we look at power, if we look at young people versus older, around 65 years of age, and very old, up to about their mid-80s, and this is work from Chris McNeil's PhD work, who worked at the center with us, you can see it precipitously drops off at around 30 or 40% of maximal force. And these are the forces that we use to walk around, to not fall downstairs, 30 to 40% of our maximal strength. And so think about that situation where we've got a 50% loss of strength and the impact that can have on mobility and reducing falls and things like that. So one way of thinking about mobility and sort of a broad marker of it is looking at something simple like gait speed. And so if I walk across the front of the room here, how fast do you think I'm walking roughly, meters per second? 2, 3, 5? Yeah, probably 2 or 3. One is this. So to cross the street in most urban areas, you need 1.5 meters per second. That's what walk lights are based on. If you drop down below 1 meter per second, most people would say that would indicate significant mobility limitations. Some people would say it's a good marker of frailty. So as we age, and here we are at around 60 years of age, 80 years of age, you can see more and more people drop down below that level that we need for basic day-to-day function to be safe and to not be in that category would say that our mobility is affected to the point that it really might start affecting our lives. But one of the things that's also important is there's a lot of variability in this, isn't there? And this is a very good study by Ferrucci. Ferrucci is one of the leaders in this area. So this isn't bad science. But when you measure this really well, there's still a lot of variability. Like what causes that variability? Why are some people so much better than others? And we're starting to understand that and being able to actually impact it. And we're going to talk about that a little bit later. So one of the things that happens as we get older, and I've mentioned this already, we lose strength and we lose some of our muscle mass. And how do we know this? Well, lots of studies have looked at the amount of muscle we have in various different parts of the upper and lower limb, the arm, the leg muscles, and so on. And this is just one example. Again, this is a study from Chris McNeil from 2007, who's out in Kelowna now in a kin faculty. And he was interested in the muscles that are on the front of the shin, the tibialis anterior muscles, and they allow us to pick our foot up when we walk. So we call them dorsiflexors because that's called dorsiflexion. Really important for normal walking, important so we don't fall, all right? And they're very important for balance because most of us balance by leaning forward, leaning backward, leaning forward, leaning backward. And that's what our muscles do over and over again. And if we look at this muscle which sits right here in front of your shin bone in a 25-year-old versus an 80-year-old, I think you can appreciate it looks a little bit different. It's smaller if you actually measure the outline of that muscle. And there's also a lot of this kind of white stuff in there. And that white stuff isn't just space, it's fat and connective tissue. And so we know from this and many other studies that have looked at, for example, the quadriceps or the thigh muscles, the upper arm muscles, and so on, that we don't just lose muscle size, we actually lose muscle. It's gone. And we've got as much muscle as we're ever going to have at birth in terms of the number of muscle fibers or cells we have. So if we lose it, we can't get it back. The question is, can we keep it? So it's not just loss of muscle mass or size, we actually lose muscle. So who here has heard of osteoporosis? I think every hand will go up in the room. Expected so. Who here has heard of osteopenia? Not as many, but some, which is a bit of a precursor. It's probably actually a radiologic diagnosis. It's a bit of a precursor to osteoporosis. You know, get on your medications, take your calcium and vitamin D at that point to try to prevent osteoporosis. Who here has heard of sarcopenia? Yeah. Wow, now I feel really lonely because should have stayed with the osteoporosis research. No. So the reason you haven't heard about it is because it's harder to measure and harder to define. And in medicine, we like things that are easy to measure. Who's heard of blood pressure? Yeah. Heart rate, cholesterol. You know why? They're easy to measure, right? Who's heard of vitality? What's the measure for vitality? How do you measure it? I don't know either. So medicine and research like to focus on things that we can measure. Scientists like to be able to measure things. So you can measure sarcopenia. It's harder to measure than bone mass. It's harder to measure than blood pressure, but you can do it. And why does this matter? Well, it matters because, in part, a guy named Irv Rosenberg in the late 1980s said that, you know what? If we define something and put a label on it, then people will start to pay attention to it. If we just say this is older people with aged muscles, it's not very sexy, that's not interesting. Sarcopenia, now that's actually cool. And so in the late 80s and the early 90s, I was just starting to do research in this area, and it was a boom. And it was great for me because people were really interested in it. But if you look at PubMed, which is where we search to see all the research papers, and you do a search before about 1987 on sarcopenia, you'll get like 3 papers. If you do one today, you'll get 30,000 or 40,000 papers in every language and so on and so forth. And it's in part because someone was smart enough to say, let's actually define this and put a label on it, and then we can start to measure it. And so sarcopenia really means age-related loss of muscle mass. So losing muscle. But it's not everybody. Not everybody who's older is sarcopenic. So how do we define that? The commonest way that it's done clinically, and in some centers this is actually being done clinically, it would be possible to have it done here, but it wouldn't be part of routine care. There would be some centers where we're starting to be able to do this, or it's being done. And so a DEXA scanner, which is the same scanner that's used for osteoporosis, can give a measure of whole body muscle and compare the muscle in the arms and legs with the muscles in the trunk and say, how much muscle do you have? And if you do that in large population studies, this is American data, you see somewhere in the ballpark of between 5 and 13%, could say probably 5 and 15% of people between 60 and 70, and this is men in this case, would meet the criteria for sarcopenia, kind of like saying you're osteoporotic. So you're lower a couple standard deviations than a young control. But 50% over 80. So again, it's that precipitous decline that seems to happen somewhere around 75 years of age, where there's a loss of muscle mass and it's measurable. And this is going to grow. Why is it going to grow? Because, as we said earlier, we're an aging population. There's going to be more and more people in that age group. So sarcopenia is complicated, and it's probably much more complicated than even this very complicated figure would suggest. I don't know, I think it's complicated, maybe you don't. Remember, I'm a gym teacher. And I love gym teachers, by the way. So decreased muscle mass and quality leads to sarcopenia. We've got decreased strength, decreased protein reserves. Often this is combined with a little increase in body weight, and that affects our mobility. Why does that happen? Some people think it's perhaps inflammation. Inflammation gets blamed for lots of things, including heart disease. Maybe there's an inflammatory component to some people's cognitive impairment. And I won't go over all of these, but these are typical markers of inflammation. But probably more so, anabolic. You've heard of anabolic steroids. Anabolic means making muscles grow. So if we take away some of those anabolic stimuli, like our brains turning our muscles on, changes in our hormones like estrogen and testosterone, our diet might change as we age, and often people, as they get older, eat less protein, and that might be part of normal aging. Changes in insulin action, which actually impact muscle, and certainly a decrease in physical activity. We can't change a lot of these things other than diet, but we can change physical activity. So a guy named Jan Lexell in Sweden, and in Sweden, frankly, you can do types of research that you probably couldn't do here. And it's not unethical, they just have a different view of what can be done. He did a post-mortem study. It was a landmark study, and landmark studies are ones that are cited over and over and over again because they change the nature of science. And this study was very interesting. He took post-mortem data from traumas, from people that, as much as they could tell, were pretty healthy, between children right up to folks 90 years of age. And why do they want to do that? Because they could get whole slices of their quadriceps muscle, the vastus lateralis, this big muscle on the side of your leg. So not just a biopsy and a guess, take out the whole muscle, section it, and be able to get a very, very good indication of what's going on with aging with that muscle. And this paper's probably been cited 10,000 times. Gives you a pretty good H factor for those of you that are science geeks. So what did he show? He showed that the average size of type 1 muscle fibers, which are slow twitch fibers, They're the ones we use just kind of walking around for posture, not for real intense activity. They don't change very much as people get older, at least in that muscle. But type 2, the types we use for higher intensity activity, for generating power, they really change in size. They get a lot smaller. And so that was a very important finding. And we kind of knew that from biopsy studies anyway. But here's the real kicker. It's not just size of the muscle fibers, the whole number of muscle fibers. And this isn't a guess. This is a count of them all. That can't be that much fun. But anyway, that's what they did. So again, look at the shape of that. You know, there's variability here for sure. But that line stays reasonably flat and then precipitously drops off again at about that age. Wow, there's a story here. So there's something happening as we get up into that 8th decade of life that really changes how our nerves and muscles function. So it's not just loss of muscle size, we actually lose muscle. So one of the questions we have asked for a long time, and you know, science does creep along a little bit slowly, is could changes in the nerve be a major factor in this? So to think about that, you have to know a little bit about anatomy and physiology. I'm going to talk to you a bit about some kind of, you know, first-year physiology. So a fellow named Sir Charles Scott Sherrington, and if you're a motor physiologist, he's your hero. Say, wow, some people have astronauts, you have Sir Charles Scott Sherrington as your hero. But that's okay. So he described in 1929, based upon observational research, the concept of the motor unit. And it's never been changed since. So he got it right. And that's pretty cool that he got it right in 1929 with the technology that he had then. It's mostly on cats. Sorry for the cat lovers in the audience. But what is a motor unit? The motor unit is the fundamental functional structure, anatomic structure of how we move and interact with the world around us. So what is it? It's a nerve cell body that sits in our spinal cord or in our brainstem. It's a nerve axon or nerve cable and a little group of muscle fibers that nerve talks to. That's a motor unit. So everything that we do in terms of interacting with the world around us, including breathing, speaking, gesturing, walking, posture, is because we turn on or turn off motor units in a very organized fashion. It's such a cool system, right? It is amazing. So we're going to talk about this a little bit more, and if you're not excited, that's not my problem. I now have the podium, so. So all force production is because of turning on motor units. They are like the pistons in an engine, or I like to think of them as the oars in a boat. Want to go faster? Row the oars faster. Want to go really fast? Put all the oars in the water. And that's the way our motor units work, in a very orderly fashion. So they sit, again, in our spinal cord, and if we think about this, they sit in very specific areas. And so if I want to dorsiflex my foot, as we talked about earlier, I turn on L5, so down in my low back, motor neurons or motor units. They send a signal to my dorsiflexors and pull my foot up. Pretty cool. So anybody that's had a pinched nerve in their back, an L5 or an S1, or in their neck, a C7, that's what they're talking about. So, again, everything we do, lifting a weight, running a race, playing a piano, smiling with an orange face. This is not the talk I give in Alabama. Maybe in Vermont. It's all because we turn on a motor unit. Now here's what we're going to do together. We're all going to put our hand, those that are able, and I think that's probably most of you, like this. We're going to put our fingers together, and we're going to do one fun little thing together. We're going to abduct our second digit using our first dorsal interosseous. Oh, come on. We're going to do this. And we're going to make that sound. So we're going to go. Awesome. So we're going to abduct and go. Okay, now together though, on the count of 3. 1, 2, 3. I can't believe I got you to do that. That's so fun. Okay, now, Simon says. So, no, not just to have you look silly. The camera's on me, not on you, don't worry. The reason I asked you to do that is that think about what you just did. That's not a novel task. We're pretty good at moving our hands. Our brains are hardwired to our spinal cords, are hardwired to the muscle. with no practice and no thought, really. You did that. But at the same time, you controlled the motor neurons that go to your tongue and your mouth to make that sound. It's remarkable that we can do that at all. A robot can't do that. No way. They can't. Not yet. They would mess it up and it would be... So our system is beautifully arranged to be able to do that. And when we're young and healthy, it works perfectly without us thinking about it, because it's all handled by systems that are, for the most part, kind of automatic. I don't talk about that. So one of the ways that we can understand this, and I'm going to talk to you a bit about EMG or electromyography, because that's really one of the major tools that I have used to understand what happens with aging and our nerves and muscles. And EMG is, in many ways, a pretty simple thing. When muscles contract voluntarily, and we turn our muscles on, so there's someone contracting their first dorsal interosseous and a little strength measuring device, not making that sound. Then if we stick a needle in that muscle, we can measure the intramuscular EMG, and it sounds like this, pop, 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 and it makes these spiky waveforms, and any of you that have come from a kin background or have done any biofeedback will have maybe seen that. And if we put surface electrodes on a muscle and we get it to contract, we get this sort of hissing sound and these smoother waveforms. In this case, the microphone is close. In this case, the microphone is further away. A needle versus a surface electrode. They give us different information, and we use those to measure a whole bunch of features about the nerve and muscle health. Some of you would have had EMGs done if you've had carpal tunnel syndrome or a back issue or numb feet, and it's a commonly done clinical test. We're using it a little bit differently in a research world. So a really smart person named Professor Alan McComas, who spent most of his career at McMaster, who I had the great fortune to spend quite a bit of time around when I was a medical student and a resident, way back in the late 1960s and early 1970s said, if we really want to understand what happens with lots of diseases or aging that affect nerves and muscles, we need a way to count nerves. You can't do postmortem studies on most people. They're not interested in volunteering. So this has to be able to be done in vivo, meaning with living people. Animal studies are a whole different thing, and they sometimes help us, but we want to do human studies. So he came up with this, and like a lot of Alan's science, a very simple concept, but then the underpinnings of it are actually quite complicated. We're going to keep it conceptual. That if you want to know how many nerves are in a muscle, all you have to do is measure you have to have some way of measuring the maximum size of the muscle. And if you can then get a measure of its constituent motor units, so the things that make up that size, if that's a representative average and you divide the all by the average, you get the number that you would need to make that up. It's simple sampling characteristics. And there's lots of ways to do it. In this case, we use an M potential from stimulating a nerve and getting a response. That's the all response, kind of like measuring the size of the muscle. And we get a sample of these things called SMUPs, or motor unit potentials, which are the size of the motor units, those things we've been talking about. It's complicated, so I like to talk about potato number estimation. I've lived in Ontario for a long time, and maybe we should change it to corn for southwestern Ontario, I don't know. But it makes it conceptually easy. If you want to know how many potatoes are in a bag, weigh the bag. If it weighs 10 kilograms and the average weight of a potato, weigh like 10 of them, is 0.25 kilograms, you got 40 potatoes, right? So this is what they would do in Carleton County in New Brunswick. They're not going to count them all, it would make no sense. So it's just a typical sampling method. And there's lots of ways to do this with nerves and muscles, which we're not going to talk a lot about in detail. This is a paper that I published way back in '93, and it's been cited lots of times, and probably more than anything that I've done since then. I'm not sure what that says. And this is other techniques that we've used more recently that base it on EMG. So again, all we need to do for this to look at how many nerves are in a given muscle is measure an all response from a muscle. For example, here in the biceps, get a whole bunch of these motor unit potentials, average them, divide the all by the average, and there you go, you have a count. And let's not dwell on it too much more than that. So way back when I was working with Bill Brown, and those of you who've been longtime Londoners may recognize or know Bill. He used to live just over here on Grosvenor. And Bill is now living in Niagara-on-the-Lake, happily, retired for quite a while. We published a couple of papers looking at the effects of motor unit losses on strength in older men and women. These have been cited hundreds of times, which is pretty cool, and they still get cited because I think we did pretty good science at that time, and we've built on that over the years. So I'm going to talk to you about what I think it really has become a bit of a landmark study that we did a few years ago. And again, this is from Chris McNeil's work. And yeah, people always ask, didn't you put electrodes on in those days, like cables on your electrodes? Yes, we did. But anyway, it's a bad picture. It's the one I have. So in this case, what we're interested in is not just saying, what happens to the group of 60-year-olds, to their muscles? What happens to people who are on that part of the curve where there's been a real precipitous decline in muscle mass, in strength, maybe in mobility? So this seems like a simple study to do, but it's actually very difficult, and it's possible to do it in part because of our links with the Center for Activity and Aging. So we were able to take a group of pretty young people, a lot of grad students and kinesiology students, an older group or cohort with a mean age of around 66, but then a group of very old, in this case men, who are very healthy. And why is that important? Because in this case, in this study, we're trying to study biology. Not so much the impact of disease superimposed on aging, but aging, as much as we're able to measure that. And that's a debate that you can have all day about, is there any way to truly parse out aging from disease and from environment and from nutrition? But I think this is about as good as you get, because these are very active, very healthy older men. So what did we do? We measured their strength in this fancy thing we call the boot, and it's again the pulling up the ankle muscle. Tibialis anterior, we measured some EMG features of it. And if you do that with this very healthy group, you find that the young, in terms of their maximal strength, can produce about 40 Newton meters. The old are, again, a very healthy group. They're about the same, whereas this very old drops off quite a bit. And don't worry about the twitch. We're going to talk about that some other day. But then if we look at the numbers of motor units they have, the nerves going to that muscle group, young, and this would be very typical of all of our data. Every time we do this, tibialis anterior has about 150 nerves talking to it, 150 motor units. And we see typically anywhere around 30 or 40% drop off in old. The very old are precipitously dropped off. And why does that happen? Because the really old folks have larger motor units, but they're not large enough to maintain their muscle mass. So as they're losing motor units, in the old, they get a little bit bigger actually. I'm going to show you why in a moment. The very old can't compensate any longer. So it's kind of like you can adopt so many kids into the family. After a while, you can't adopt any more kids. You can't afford to buy them groceries. So what happens as we age is we do lose motor nerves. And so they die. But a healthy nerve tries to adopt or pick up those denervated muscle fibers. And that works pretty well. The same thing happens in nerve injury. Same thing happens in diseases like polio or ALS to a degree. But nerves are not perfect, and motor nerves can only look after so many muscle fibers. Eventually, that process starts to fail, and we end up dropping off some of those muscle fibers. And that's probably the explanation for Lexell's study that shows those muscle fibers dropping off in the very old. And so if you're to look at, for example, a biopsy of the vastus lateralis, the side of the leg muscle, this is a young, healthy person, and the red ones here are slow twitch, type 1. The bigger ones are type 2, the fast twitch. Look at the older subject. Start to see this grouping of the type 2 because we're getting collateral reinnervation, and the type 2 are actually a lot smaller. Again, it's that type 2 atrophy, a weaker, slower muscle. So we know a lot about aging and what happens with motor units as we age. We know we lose them, they get bigger. We get a larger type 1 fiber area, so it's a slower muscle. We lose some of the size of our type 2 fibers in terms of their size and actually the number. So loss of strength, we get slowing of muscles. The muscles fire a little slower on EMG. And this thing called neuromuscular junction instability is kind of a hot area right now that we're working on, but it really says that the nerve has a hard time actually sending the signal to the muscle, right at the muscle itself. And that can fail and probably leads to reduced contractile strength even in the muscle that's there. So that's an awful lot of doom and gloom, right? So let's change that, okay? Let's start being a little more positive and talk about some of the things that we can do to counter sarcopenia, to maintain our muscle health, our muscle strength, and our mobility as we get older. There's a lot of things you can do, and we're going to talk in most detail about exercise, because by far, exercise has been shown to be the most potent way to maintain muscle mass, strength, health, mobility, being able to be active as we age. So these other things like adequate protein and total caloric intake are important, but if you're not increasing your exercise or maintaining exercise, it probably won't matter. There certainly is some evidence that we need to maintain our total body mass. Now, as we get older, and I can attest to this myself, we all can, our body mass composition changes a bit, right? I weigh about the same as I did when I was 25, but my composition is not the same. So my body fat has gone up, and my muscle has gone down. Wow, it happens. So, but we do also have to maintain our body mass, and there's actually some interesting evidence that as people get more frail, they actually lose total body mass, not just muscle, but also muscle and adipose. And then that is a marker to some extent probably of nutritional failure. So those are things that we do need to keep an eye on as clinicians, but that's a little bit different than we would see with typical aging. Hormonal supplementation, as you can imagine, has gotten a lot of interest, especially for men, testosterone replacement. It hasn't worked very well, though. We could talk, it could be a whole talk on this, but there's a lot of side effects, and some of the concerns around things like prostate cancer, and also other side effects that testosterone supplementation, not replacement for people who have really low testosterone. This is supplementing people who are either low normal, or normal. Hasn't worked out very well, and it doesn't seem to improve people's strength and function, most importantly. There have been tons and tons of other pharmaceuticals that people have tried, as you can imagine. Can you imagine if you could come up with the pill that maintained muscle mass and strength as people get older? I don't think the shareholders of that company would be worried too much going forward, because it's the whole world market, but no one's found it yet. I certainly haven't. But this is like a pill, and we're going to talk about it. So this is not new, folks. I wish I could tell you that this is completely new. We just invented exercise for older adults. So go way back to Cicero. I have known nothing about ancient Greek philosophers. For that matter, he was a Roman. What is it? The wise man keeps his mouth shut and leaves at least some doubt, and the fool opens his mouth and removes all doubt, and something like that. It's like a George Bushism. Anyway, I'll carry on. Again, gym teacher. So, ages ago, and what did he say on his essay on old age? It is our duty to resist old age, to compensate for its defects, to fight against it as we would a disease. It's interesting. That's rehab in many ways. That's what we're seeing in the Today section of the Free Press about aging and staying active. It's not a new thing. What else? To practice moderate exercise. That sounds like pretty good advice. To take just enough food and drink to restore our strength. Well, a guy named DeLorme and his partner Watkins, and DeLorme was an Army sergeant in 1945, they coined the term progressive resistance exercise, PRE, which is really strength training, and said that if you take somebody, for example, in this case, who would have been a soldier coming home following the Second World War with an injury, and you exercise their muscles, lo and behold, they get bigger and stronger, and their level of function goes up. Pretty simple. And so some people say that DeLorme, he was a sergeant in the Army, in the U.S. Army, is the father of rehabilitation. But that's not true, because he's a Canadian. William Tate Mackenzie was the first rehab doctor that anybody knows of, because following the First World War, he took soldiers coming back in Montreal and put them in exercise programs at the gym at McGill. So just like most great things, it's a Canadian story that the Americans have tried to steal, like basketball. That's open for debate, because it happened in the US, but this happened in Canada. And so really, Tate Mackenzie, who was a Renaissance man of all Renaissance men, knew this and got a lot of people back to levels of function that allowed them to live their lives, and that's rehab. So what about some science around resistance training in older adults? I could show you now 1,000 studies, and there really are 1,000. A lot of them not very good, but these are the landmark studies that people talk about. So Maria Fiataroni, who is a geriatrician who was working at Tufts New England Medical Center when this was done back in the late 80s, early 90s, published 2 papers, one in JAMA, not a bad source, so one of the top medical journals in the world, and then this not so great journal, New England Journal of Medicine. And so to get really what are geriatric rehab papers in those two journals is pretty impressive. So at any rate, what did they do? She took a group of very, very old men and women living in a long-term care facility and put them through a standard strengthening program of high-intensity progressive resistance exercise, doing things like leg press and leg extensions and chest press and chest pulls and so on. And now we kind of think of that as, yeah, people do that all the time. Not then they didn't, because there was fear that they would get injured, that they wouldn't improve, and in fact, they might decline. But what did she show? She showed that their knee extension strength, so that's the kicking the leg out strength, increased by almost 200%. So these were not very active people before, so a lot of that is just increasing being able to use what's already there. But they were also able to increase their actual muscle mass by almost 10%. You say, why the difference? Because part of it is your brain learning again how to use that muscle, but then the muscle also gets bigger. It's the two together. And in every study that's ever looked at resistance training or strength training, the amount of weight you can lift is always way more than how much the muscle grows. That's just the way it is. And so that was a landmark study. I mean, she went from there to the speaking circuit, literally, and then wrote 2 or 3 books, and I think she made a lot of money and retired. I should have done that. The New England Journal study actually added a protein supplement, but didn't show any more improvement from the protein supplement in this case. But these are probably people, because of where they were living, which is actually a very high-end long-term care facility, probably had pretty good nutrition. There's been other studies since that have shown that people who are not properly nourished, if you add a supplement along with training, that they'll actually get a significant benefit. And so, again, I could show you lots of studies, but basically they all show the same thing. If you take men and women from 60 to 80 to 90 years of age and put them in a progressive resistance exercise program, they will get stronger and their muscles will get a little bit bigger. And that's great, but when you're 20, you might like to walk around and say, guess what I can bench press? Not as common as 75, because I think people start to focus on more important things in life, like what's my mobility like? Can I still go curl? Can I play golf? Can I get out into the community and do the things I want to do? So function is really much more important than size of muscle as we get older, and probably is true throughout life. So if you look at large, what we call meta-analysis studies, so that's taking a whole bunch of studies and looking at them together. So that's called a meta-analysis. And you say, well, what happens with strength training or resistance training in terms of function? Here's what they would show. Mobility gets better. So people walk faster. They're less likely to have difficulty with things like stairs or getting up out of a chair. They're more likely to be more active in the community, so they will do more, and those are markers of mobility. They walk faster. Their balance is better if we measure balance. Fall risk reduction, hard to say. The challenge with fall risk reduction in a study is that if you have a study with 60 people in the training study, and you have 60 people in the control arm, you need a significant number of falls, correct, Roy Butler, epidemiologist, in order to have enough power to see a difference. And a lot of the studies are underpowered, which means that, okay, one person fell in the control arm, one person fell in the treatment arm, who knows? And so a lot of these studies have been underpowered. There's a move to do much larger studies, and this has been happening for the last 5 or 10 years, but literally we can't yet say that definitely strength training will decrease falls and injury. I'd like to be able to say that, but I would be not feeding you fair information and not giving you a balanced approach here. But certainly when we look at markers of mobility, they improve with resistance training, and some studies, but not all, have shown fall reduction. So if we think about what do we recommend for people, what are some recommendations? And a lot of it is pretty similar to what you would see in any indication for for basic exercise in middle-aged to older adults. There's not a lot of difference in Canadian guidelines or American guidelines or European guidelines. But what they would basically say in terms of strengthening is that most older adults, and they're talking about people between 60 years of age and older, should do 2 times a week, 8 to 10 exercises of their major muscle groups. So that's things like quadriceps, our muscles that allow us to rise from a chair, so our hip extensors, muscles around our chest, and upper arm and shoulders, and about 10 to 15 repetitions. And this is the key, and this is where it gets challenging, at around 60% of the most weight that you can lift. And that is reasonably high intensity. And this is why we are a little bit challenged in programming for strengthening exercises to work on our neuromuscular function as compared to aerobic exercise. It's a lot easier to do aerobic exercise at an appropriate intensity without a lot of supervision and without a lot of equipment. Because you can measure your heart rate, or you can use the fact that, yeah, I'm not out of breath, but I'm feeling like I'm working, and that's where we would suggest that most people do basic aerobic exercise, walking, cycling, swimming, and so on. 60% of 1RM will feel quite intense to most people that aren't used to training. And it generally needs guidance. It needs a controlled environment initially to get started. But there are ways that we can do this without an awful lot of equipment and shown, and we can talk about that later. But that is a challenge, but in order to get the benefit, there has to be a minimum intensity. And why is that? Those type 2 motor units, those type 2 muscle fibers, the ones that we're really trying to target, that are getting smaller as we age, we got to turn those on. And the only way you turn those on is by doing exercises at least 50, 60, 70% of maximum. And so there are more and more ways to do this, and there are more and more programs available for people to do so, but we do need to figure out how to do this in a better way, in a way to target more people and allow more people access to this kind of exercise. So one of the things that we're also learning is that including exercises that work on balance and flexibility as well as strengthening are probably, especially as people get into their 70s and 80s, perhaps more effective than strength training alone to improve mobility, to decrease falls, and so on. And it makes sense. Why? Because in a progressive way and in a way that's enjoyable, we are working on things like balance and flexibility. Like, I don't think I can do that, actually. I can't get my leg out and then bend that far. I'll tear my hamstring because I'm a cyclist and we all have terrible flexibility. But that is not an easy skill. Why? You've stepped outside your base of support, right? And as soon as we do that, we feel unstable. And we're doing an action at the same time. That makes our brain work. It makes our muscles work. And we have to do it in a coordinated fashion. So things like Tai Chi, yoga in some forms and so on, there are now large studies being done to look at those to say, what's the best way to do these? Not just do them, what's the best way to do it? How often, what types of exercises and so on, and there's some interesting results from that. And Allison is here, so I'm in trouble because, yeah, she knows exactly where this is going. There is very interesting evidence that dance, and it doesn't have to be ballroom dancing, it could be square dancing, it could be Scottish country line dancing, Jillian could be Scottish country line dancing, is very effective in maintaining balance and maintaining mobility. Why? Well, I'm not sure if Dr. Montero Adasso has done one of these yet. If not, he should, because he's a great speaker, and he would talk to you about what they call dual task training. Dual task training is where we do something with our muscles usually or our balance, but we also do something with our brain. And why is that important? Because as we get older, we're not as good at doing that. And so I can walk to some extent still and think, although generally either the walking or the thinking isn't great. But as we get older, the parts of our brain that we use to dual task are more and more challenged because we have to kind of parse out different parts of the brain to do that. And it's interesting that it has been shown that activities like ballroom dancing, even if you start when you're 75, have an impact on balance, on strength, and on mobility. But there's an additional thing that I think is very important. There's also a social connectedness to this. And we know that as people get older, they are less likely to be in the community. They are less likely to be around their peers and people who are of their age. And unless there's maybe an organized way to do this, we don't do it. And so there's a real move toward trying to increase the numbers of programs like this that are also targeted and intentional. And I think the more we do this, the more we'll have an impact on our societies as a whole in terms of how well people are in general. Not just their nerves and muscles, but also their mental health and their physical health. I mean, that's true body, mind, and spirit here. This is everything. And yes, I will start at 75, and I've committed to that now. But I've still got a little reprieve. The reason I say that, I'm a terrible dancer. I'm terrible. Anyway, that's a long story. So, if I was going to say to you, what should we do as individuals to maintain our mobility, maintain our nerve and muscle health, and to be as function at a high level as we can? And I haven't just thrown this together with a bunch of pictures. This is truly what the literature would suggest. I could show you a whole bunch of studies and you'd be bored out of your mind. So when we are young, and I've just sort of transparentized this because I don't really know a lot about kids and exercise, it's not my focus, other than hanging around a lot of gyms and ballet studios over the years with mine. But as we get older, probably the right thing to be doing, and you can do anything anytime, but if you're going to say what's evidence-based, is to focus initially on aerobic activity. Why? To maintain cardiovascular health, to maintain brain health, to maintain our body mass appropriately. And it probably doesn't matter from a health perspective if you do a lot of strength training. You're going to be fine anyway. And again, this isn't elite athletes, this isn't people training for sport. This is health. As we move into our middle age, and that is somewhere in the mid to high 60s in my view now. It is plastic, isn't it? Huh? You're going to live to be 140. There is pretty good evidence that we should continue with aerobic exercise, but we should start to do some strength training. And that's about the time that if you've never done it before and you don't care about it, you should. And that's, for example, why a lot of exercise programs for older adults are starting to incorporate strengthening exercises as well as aerobic, because we know there's evidence that that will change the game for those individuals. And then perhaps as we get into our 7th, 8th, 9th decades, as lots of us will, it makes sense to start to do a lot of body weight supported type exercise, which you can do anywhere, but combine it with activity that makes us use our brain and our bodies. And I think the more that we can promote this kind of progression and give people pathways to do this, the better we will be in terms of the health of our society as a whole. And if you want, I can give you 1,000 papers that'll describe this for you. But that, in a nutshell, is if you spend 300 or 400 hours reading, you'll come up with that for the most part, with a little bit of wobble around it. But that's science. So I am going to stop there because I think I was supposed to stop before 8. And just to summarize, we are aging as a society, and that's a great thing. Of course it is. This is what we all do for a living. We try to keep people healthy. But it does provide challenges to our healthcare system. And I have, I think, demonstrated to you that our nerves and muscles will change, and that's inevitable. Doesn't matter who you are. That very healthy group I showed you of 82-year-olds from the Center for Activity and Aging, they still have a loss of muscle and a change in their nerves. And although we say, gosh, he seems to talk about that a lot. Yeah, my whole career is based on this. Loss of motor units is an important contributing factor to loss of muscle mass and strength. And that's science. You focus on one area and you just keep hammering it. Resistance exercise is really proven to improve strength, muscle mass, and function. And maybe adding some balance and cognitive tasks along with some social connectedness would be the most effective thing as we're in our older adult life. I'm going to give a little acknowledgement to just a few groups and people. Thanks to St. Joe's Healthcare Foundation for hosting and organizing this event tonight. I'm a proud member of the board, because you never really leave, do you, Michelle? you just don't have to go to the meetings anymore. Lawson Health Research Institute supports all of the research we do within the hospitals and healthcare system here in London. My long-term collaborators, Charles Rice, who is a faculty member in School of Kinesiology at Western, and he and I have done a lot of this work together and are fortunate to share graduate students, and they do a lot of the work and get a lot of the glory, and they should. Dan Stashik and I have worked together for years, and he is in systems design engineering. Those fancy EMG signals I showed you, it looks pretty easy, but to actually take those and then get the information we want takes a lot of computer programming, and I'm not a programmer, and he is. So students, Jeff Power did his PhD with us, Chris McNeil did his PhD with us, Brian Dalton, not Dalshin, Maddie Allen did his PhD with us, Madison Hurrigan, her master's, Kevin Gilmore and Neil McKinnon, our current PhD students, and we're still trying to move there's got to be a word for that. Sorry? Needle, thank you. We're still trying to move the needle a little bit along in terms of our understanding of what happens to us as we age in terms of our nerve and muscle function. And with that, I'm going to show you a nice little picture of an area in the Canaan Valley in West Virginia, and that's Dry Fork. And I spent a lovely, 4 days there sitting on a porch looking at that view. Can't go wrong with that.
I'm Roy Butler. I'm the Vice President of Patient Care and Risk Management here at St. Joseph's Healthcare. And I just want to thank Dr. Doherty for reminding me that 30 years ago I was 25% stronger, 20% faster, but I'm taking reassurance that I can do still, so that's good. DocTalks, there's still one more session in 2019. It's on November 13th. Dr. Rokeya Mather, who is one of our ophthalmologists here, will be talking about dry eye disease and ways to intervene with that. And she'll give a fantastic talk. Lastly, I want to thank our corporate sponsor, CIBC, for their sponsorship of tonight's event, and all the individual donors who make our medical innovation possible. If you'd like to know how you can contribute to St. Joseph's, anybody in the foundation will be glad to talk to you tonight. So Michelle, I've done the public service announcement on that. Otherwise, enjoy the rest of your evening. It's a beautiful night out there, so enjoy your evening, safe travels, and thank you for coming tonight.